Good afternoon. This is Dr. Havens with our recorded lecture on the second of our 3 chapters for Unit 4. In this chapter, we will be talking about healthcare quality and safety. You are becoming a registered nurse at a time when issues of quality and safety have come to the forefront in the healthcare professions. Patients place their lives in nurses' hands, and they trust us to be knowledgeable and use our best clinical judgment at all times when we make decisions about their care. However, sometimes mistakes do come, they do happen, and there are ways that the quality of care that was provided could have been. As an RN, you may be asked to contribute in the improvement of quality and safety within the healthcare organization that employs you. To do this, you need to understand that when we work within a system, there is likely to be a breakdown in that system at some point, and this creates room or risk for error. So in the next few slides, we are going to discuss and explore reasons for errors, why this happens, more about quality and safety, and how nurses can help to create a culture of safety that reduces errors and improves quality and safety of patient care in all the care that we provide. Let's start our discussion by defining what quality and safety are. The World Health Organization defines safety as the prevention of errors and adverse effects to patients that are associated with healthcare services. The AHRQ, or Agency for Healthcare Quality, defines safety as freedom from accidental or preventable injuries produced by medical or health care. Hospitals and skilled care nursing facilities have safety indicators that are monitored and reported regularly to assess harm prevention. Let's talk about the patient safety indicators and what do they mean for things that can go wrong related to surgery, childbirth, or other medical procedures. So the PSIs are a set of 26 indicators developed by the Agency for Healthcare Research and Quality, or the AHRQ. This list can be used to help hospitals and other healthcare facilities assess the incidence of adverse events and identify issues within that particular facility that need further study or review. And you can click on the links and find out what's all is on the list of the 26 PSIs. But just to give you an idea of a few, these include grade 3 and 4 decubitus or pressure ulcers, any retained surgical item, or what we call a surgical souvenir. This is when a sponge or something else is left in a closed surgical wound after the procedure. Any bloodstream infection or sepsis related to a central venous catheter, any post-operative hip fracture in the hospital from a patient fall, any perioperative DVT, deep vein thrombosis, or either a pulmonary embolism that happened in the course of surgery, any post-operative wound dehiscence or opening of the surgical wound, and so on and so forth. So what are the characteristics of quality health care? How do we know if we're doing it right? How do we know when we get there? So patient safety in terms of avoiding injuries to patients is paramount. Effective care, this is our evidence-based practice, providing only nursing services that are based on scientific knowledge, and avoid refraining from services that are not likely to benefit the patient. Patient-centered care is care that's respectful and responsive to individual patient preferences, needs, and values. This is also one of the CUSIN competencies. Timely care, reducing wait times and harmful delays contribute to quality care, doing things in a timely manner. Efficient care, avoiding waste is important also, and equitable care. This has to do with the concept of social justice that we discussed in Unit 1. The quality and care does not vary in quality because of gender, ethnicity, geographical location, or the patient's socioeconomic status. In the U.S., it is estimated that medical errors may account for as many as 250,000 patient deaths per year. So this is very important that we address quality and safety. Some of these are the results of poorly coordinated care, somebody dropped the ball in referring the patient to a specialist, and so on and so forth. Some of these are patient falls within a healthcare facility, medication errors, handoff errors, diagnostic and surgical errors, and what we call healthcare acquired nosocomial infections, or HAIs. This is getting C. diff in the hospital or other infections. So the AHRQ estimates that as many as 1.2 million adverse drug events occur annually in the U.S., and about 50% of them are probably preventable. HAIs may result in deaths. We know that it results in increased financial costs as well as extended hospital stays for patients. So what are some HAIs? As we said, C. diff infection is an important one. Also, urinary tract infections, surgical site infections, pneumonia, and bacteremia. Handoff errors are a break in continuity of care because communication was not adequate and information didn't get passed on at the shift change report. These are, for the most part, just the result of communication errors. And another significant source of error is misdiagnosis on the part of physicians or clinicians. Approximately 80,000 to 160,000 patients suffer significant permanent injury or death because of diagnostic-related errors every year in the U.S. This is the most common source of medical error in emergency departments, failure to properly diagnose the condition that the patient came in with. Diagnostic errors occur more often in some specialties than others, like neurology, oncology, and cardiology. The National Academy of Medicine, formerly known as the IOM, wrote a very important report called "To Err is Human," and in this report they categorize the types of medical errors that are very common in U.S. healthcare facilities. It was concluded that 70% of all medical errors are preventable. There are two types of errors they studied that warrant further discussion. These are near misses and adverse events. A near miss, or an error that's sometimes called a good catch, is an error that results in no harm or either very minimal harm to the patient. An example of a near miss or a good catch is a medication error. The medication has been poured up, but it's caught that it's the wrong medicine before the med is actually administered. An adverse event is an injury to a patient that's caused by the healthcare provider rather than the underlying condition or the disease process that the patient actually has. There are four types of adverse events. They're diagnostic, treatment-related, preventative, and other. Risk management is the process of identifying, treating, analyzing, and evaluating any real and potential hazards to patient care in a hospital or other type of healthcare facility. Most healthcare organizations will have a risk manager who evaluates the adverse events, error reports, and any safety errors or issues that are happening in the hospital, and they report the relevant information to state and federal regulatory bodies. So as a nurse, it's our responsibility to report adverse events to the risk manager, and actually in most states, this is a legal requirement. Risk events are categorized according to the magnitude or severity of the occurrence. It could be minor, could be more serious. And then a sentinel event is defined as an unexpected occurrence involving serious or permanent physical or psychological injury to the patient or death. These events are called Sentinel because they signal the need for an immediate investigation and response on the part of the healthcare organization. They also require immediate notification to the risk manager and senior leadership. So the risk manager is going to conduct a really thorough investigation to identify the cause of this event. Changes in the organization systems and processes are going to be made to reduce the possibility that this type of thing could ever happen again. So our next topic is never events. Never events are considered shocking medical errors that should never happen. This has to do with any time there is a suicide of a patient in the setting where they're receiving 24-hour care, infant abduction or discharging the baby to the wrong family, any rape or sexual assault of a patient, any transfusion reaction involving blood or blood products, surgery on the wrong patient or the wrong body part, and so on and so forth. Here are some steps that you can use to ensure delivering safe, quality, patient-centered nursing care. Use your critical thinking skills, plan and report outcomes. Remember to write an incident report for any adverse event in which you are a part of. Make introductory rounds at the beginning of your shift with the interprofessional team and provide patient updates. Plan in partnership with the patient, set goals and objectives, communicate the plan to avoid confusion among members of the interprofessional team and other members of the nursing team, and then evaluate progress throughout the shift. How are we doing? Are we meeting our goals? Are we off track? Have we dropped the ball on anything? And do we need additional help to get this care done? In order to achieve and maintain high quality, safe patient care in the organizations in which we practice, a culture of safety must exist. In a culture of safety, we promote trust, honesty, openness, and transparency around any errors that have happened. Research has shown that health organizations that practice a culture of safety have fewer reported cases or adverse patient events. In a culture of safety, individual practitioners such as nurses and doctors don't fear being blamed or reprisal. They are encouraged to make reports of adverse events. Event reporting systems hold organizations and practitioners accountable, and they lead to improved quality and patient safety. Let's talk about root cause analysis. The Joint Commission recommends that a root cause analysis be conducted for every Sentinel event that happens in a healthcare facility. This is the process of learning from consequences. The consequences can be positive, but most root cause analyses deal with adverse consequences. An example of a root cause analysis is a review of a medication error, especially one that resulted in severe complications or adversities or resulted in a patient death. The root cause analysis determines what influenced the consequences, what happened, what caused this outcome. It establishes a very tightly linked chain of influence, and this influence means what caused what, basically. And it will usually drill down to the root cause of what really happened and why. And with most adverse events, there are usually multiple root causes. It's not just one simple thing or one breakdown. So there can be several breakdowns or cause and effects of adverse events. There can be human factors. Maybe you're short-staffed because some nurses called in and there's no one else to cover. There can be equipment failures. There could be just a variety of things, a breakdown in a process, maybe materials failures, different medication vials look almost identical, so the patient gets the wrong kind of dose, and so on and so forth. I want to say a few words about the quality improvement process. QI has always been a part of nursing ever since Florence Nightingale's day. The goal of quality improvement is that all patients should experience the safest, highest quality, best value healthcare services across all settings. QI is dependent on teamwork. It's no one person's job to get this done and make healthcare high quality. The purpose is to continually improve the capability of everybody involved to provide the highest quality, safest patient care. And QI also aims to proactively avoid a culture of blame, providing a path to improve the standard of care for the entire system. Maybe one person made the error, but instead of blaming them, we're going to use this as a learning experience and a teachable moment to improve the whole system so that it doesn't happen to anyone else. QI involves a process kind of like the nursing process. It identifies area of concern. These are called QI indicators. They continually collect data on these indicators. They analyze and evaluate the collected data, and then they recommend and implement any needed changes. Some common safety indicators that evaluate the quality of care that's being provided in the hospital or facility are number of patient falls with injuries, frequency of medication errors, the incidence of stage 3 and 4 pressure ulcers or skin breakdown, and also hospital-acquired infections. Many U.S. healthcare organizations use a model called FOCUS, F-O-C-U-S, in maintaining patient safety and quality. And it stands for F, find an opportunity to improve. What is some areas where we've had adverse events or errors? How can we improve? Then O is organize a team, usually the interprofessional or multidisciplinary team, to work on this problem. C stands for clarify the process. U is understand the root cause, drill down and find out really what happened to cause this medication error. Maybe did 2 pills look exactly alike? So Mr. Smith in room 436 got the blood pressure pill instead of the cholesterol pill. And then finally, S is create and start an improvement process. How are we going to change the policy and procedure? How are we going to better educate nurses and pharmacists, and so on and so forth? Another concept to be aware of in patient safety and healthcare quality is the structured care methodology. These are what we call best practices. They're guidelines, protocols, standards of care. Some facilities call them clinical pathways. Sometimes they're algorithms. They don't take the place of our nursing judgment, but basically they're just guidelines about the best things to do in any type of clinical situation to avoid a medical error. Some aspects of care to be evaluated in the QI process are structure, process, and outcomes. Facilities is part of it. Is the facility adequate? Do you have enough support services? Is there physical safety? Do they do fire drills and disaster preparedness? Is the equipment state of the art? Is it adequate? And are staff skilled in the use of the equipment? Are the staff properly credentialed and educated? Are they experienced? Is there excessive turnover and absenteeism? And are the patient-staff ratios adequate? And then the other part of it is budgetary or financial. Are the salaries adequate to attract well-qualified healthcare workers? Is the money adequate to operate the facility and keep it in good working condition? And is there an adequate source of funds? So one of the most significant quality initiatives is called the National Database of Nursing Quality Indicators. You can find this on the nursingworld.org website. These indicators reflect the quality, process, and outcomes of nursing care, and they're continually updated. The American Nurses Association has a very strong focus on safe nursing staffing levels to provide safe and high quality patient care. The ANA is there to promote nursing and also to lobby for us in the political arena, and some states have already initiated state statutes related to nursing staffing ratios. Florida is not there yet, to the best of my knowledge. So the 5 core competencies that have been identified for QI initiatives and patient safety are patient-centered care, which we've already discussed is one of the QSIN competencies, working in the interprofessional teams that we've discussed for the past couple of weeks, using evidence-based practice or research-based treatments, which is another QSIN competency, applying the quality improvement process throughout patient care, and also using informatics, which is using information technology to support decision-making in nursing. Registered nurses play a vital role in decision-making within healthcare organizations. Our role and our attention to the course of everyday practice gives us regular opportunities to help improve processes that can reduce the risk of harm and improve the quality of care. Thank you.